That's working really.
Should we start?
Sure.
Yeah. So this is this. I like talking about this after talking about prognostication because we always, I think the hard part when we're talking about a specific case is what happens if you actually do discuss prognosis with someone, but they may bring up something like the fact that they're hoping for a miracle, which I think is a very profound thing to actually hope for. And I think I used to be deathly scared from it, but the one thing that has reassured me from the hope for the miracle, at least in some way, there's a realization that they understand prognosis. Else they wouldn't be hoping for a miracle. Although we'll talk a little bit more about that. And I also think it's interesting how the other thing that I think is fascinating is the concept of futility. So what's futility?
Care that will not have a meaningful recovery.
So who defines what meaningful is?
Usually the physician.
Yeah. So like we had a patient who was in a permanent vegetative state. That was a meaningful place for the family members who wanted to continue dialysis for the patient because that was an acceptable quality of life that they felt for this patient. Every physician would disagree. So who actually decides when we use a concept of what we call qualitative futility of what's a reasonable life? What's a reasonable quality? There's physiological futility, which is A will not cause B. So treating somebody with a statin for meningitis is just not going to work. There's no evidence. Coding somebody who's on 4 pressors in the ICU and who has metastatic cancer is not going to work. Unless that they just choked on a piece of steak, but honestly, if they're on 4 pressors in the ICU, they're not. And then there's the concept of quantitative futility, which I probably hear about the most, is we got a less than 1% chance of something occurring. Getting kind of similar to this miracle idea of something that it's the exception to the rule. So what are your thoughts about quantitative futility, less than 1% chance? Should that be our standard as far as futility is concerned?
It depends if there are a number of people. Some people like numbers or appreciate them.
Yeah, and I think physicians in general love numbers, and that's why we like quantitative futility. We have a set number, less than 1%. Patients don't really care so much about numbers in that regard. Some of them do, but as physicians, we love that stuff. We'll eat that up every day. So we like the concept of quantitative futility when we're thinking about going against the wishes of the patient or family, because the numbers are there. So I think the hardest thing is, have you ever done something that was quantitatively futile? Like what?
Oh, there was a patient I was taking care of when I was a resident who had pancreatic cancer and was dying in the ICU, and he had potassium levels that were going down every day. We gave him potassium, continued to go down. And so we were just in this vicious cycle of giving him electrolytes, and he was clearly dying.
Yeah. I guess the question was, have you ever done something for yourself that's quantitative?
You're talking about the lottery?
A lottery is a great example, right? If you've ever played the lottery before, you've done it a quantitative futile action for that definition. Why did you do it?
Because
Can't win if you don't play.
yeah.
Well, think about that also when we're thinking about this talk with a miracle, is you can't win if you don't play. That could be a family member's perspective. Well, of course he's not going to survive if you're going to take him off the breathing machine. how is he going to win? You're not even allowing him to play. And then, so what was the risk of playing lottery?
Losing $1.
Losing, is that a big risk or a small risk?
Small.
Small. What was the benefit?
Being financially secure, I guess.
Yeah, not even financially secure, but getting a buttload of money. That is tons of money for you. So there's huge benefits and minimal risks. And that's how, as humans, we make decisions. Is that if the lottery was $10, you may question. If it was $100, you probably never played the lottery. If it was $1,000, probably nobody would play the lottery. So it depends on the level of risk, and it depends on the level of benefit. If the lottery would give you $2 instead of 10 million, you probably wouldn't play it. So think about that concept also in the ICU setting, or when you're talking with patients. I never use the term futility unless if it's like physiologically futile, just because that's not how people think about what are important outcomes and the likelihood is. So they think about what are the risks, what are the benefits, and far too often we just focus on the likelihood of benefits and not the likelihood of risks. So that's why I like talking about this, is because it includes prognosis, it includes thinking about goals, it includes a lot about communication. And the other part I liked about this is that we actually ended up publishing this. And it does show that when you're talking about issues around spirituality, you can get it peer-reviewed, and you can publish it. And that communication in and of itself is both a skill and something that should be researched into. That it is just as important as whether or not a statin will prolong life. Knowing communication techniques, and even looking up questions about how is the best way to approach patients who are dealing with a miracle. You can actually look that stuff up, and there's information out there in studies that you could use. So if you can use it for something like a hope for a miracle, you can use it for other aspects of communication. So I'm just gonna, this talk is basically going to be how I actually, this is a real case that I had to deal with. Some aspects were changed to protect patient confidentiality, but this is actually how I used evidence-based medicine to help me guide how best to approach patients who hope for miracles. So this is the case. This is Mr. L. He's a 60-year-old homeless veteran who comes into a physician with hemoptysis and weight loss for the last 6 months. Physician orders a chest x-ray, and we see a very large, right-sided, here's the mass. Patient was lost and found. So chest x-ray was done, left, never came back. Repeated attempts to bring him in for the next month failed. Comes to the emergency room with dyspnea, is emergently ventilated. A CT scan was ordered. What we see is a large necrotic right-sided lung mass. The right main stem bronchus is nowhere to be found, completely obliterated by the mass. This little fish mouth of opening is the left main stem bronchus. The mass is invading into the atria, so it's now invading into the heart. He is on the ventilator. He is bucking the ventilator. He requires massive amounts of sedation to actually prevent him from bucking the ventilator. And he does not have capacity to make any decisions at this point because of that. Multiple attempts to lighten up on the sedation failed because his pressures would dramatically increase on the bed. So a discussion happened with the mother, with the ICU team, the palliative care team, and this particular mother of the patient. A discussion occurred about what was going on with his health, what happened in the ICU, the likelihood he would ever leave the ICU, which was said that he would never leave the ICU because of what's happening here. I forgot to mention, the biopsy came back. Actually, it was a bronch, and the bronch results came back as non-small cell lung cancer. Oncology also consulted, and they said they will not touch no chemotherapy as long as he's on the vent. And because of this is the only airway that's open, he was never going to be coming off. And that was discussed with, so prognosis was discussed with the mother. And she says, do everything. I am hoping for him. The physician in charge of the case was frustrated. He was angry. Didn't she hear anything I said? Doesn't she care about her son? He's dying here in the ICU. Is this how she wants his death to be? And again, he is incredibly frustrated here, and he wants to know what to do, or what should I have done differently, because he feels this has gone incredibly bad. Which is a normal, healthy reaction. Like, it's actually good to have emotions. It's good to feel angry. That means that you're not burnt out and that you can't have emotions anymore. So, it's important to reflect on that. And this physician did reflect on it. Like, why am I feeling this way? Why am I angry at this mother? And it's good to actually, and reflection is really important for a self-care exercise, but it's also important to take that next step of not only just reflecting on how you're feeling, but to take a little bit of outside perspective of saying, okay, this is how I feel. Let me try to turn the question around. And this is a great way to turn the question around is, why would a reasonable, rational, and decent person do that? And it's important to say that it's not this lady's disposition. And this is oftentimes what we think about it. Somebody cuts you off while you're driving to work. You think, this guy is just a mean old person who cuts everybody off, who's driving erratically. It's his disposition that's causing this. It's not situational. It's not that because he's late to pick up his son at daycare. Although if we cut somebody off, we often think about the situational aspect. I'm not a bad person. I'm just running late to work. And this is a natural, I forgot, actually there's a bias that's actually a specific term for this, but it's a natural human reaction to think other people, when they do something egregious, it's dispositional versus situational when we do it. And it's important to actually turn that around, and this is a question to turn it around. Why would a reasonable, rational person do that? So, let's develop the question. Let's figure out how we could actually figure out this out using evidence-based medicine. For again, one of the harder topics is about spirituality, because there's not a whole lot as far as evidence, but there is some. So how do we actually design a good clinical question? So PICO, what's the patient or clinical problem? What's the intervention exposure? What's the relevant comparisons? And what's the outcome of interest? It's really hard to do this. At least I couldn't. Maybe you guys can, to develop one question around this case of using PICO to come up with one question that can help you figure out how best to approach patients who are hoping for miracles. I tried it for a long while, couldn't make it up, so I developed 5 questions using it to help guide me. So what are those 5 questions? We're going to go through each 5 of them. So the first is just to give us a general frame, which I think is really important. So among the general public, what is the prevalence of belief in miracles or divine intervention? What do you guys think?
General public?
Right. Not you. Because I can promise you the rates of belief in miracles, religiosity in this room is much lower than the general public.
70%.
What is it?
70%.
70%. Sound pretty good, everyone? No. So, interestingly, rates of people being affiliated with any particular religion in the United States has gone consistently down decade after decade for the last 40 years. However, belief in things like heaven or hell, divine interventions or miracles has remained remarkably consistent. So people's spirituality and even levels of religiosity hasn't really changed. People's specific affiliations with religions has. So that's an important concept to remember. And when you ask, this is from Pew Research, a survey that they've done in 2010, you ask patients, or you ask individuals in the general public, the likelihood that they believe miracles still occur in ancient times. I don't like how they ask that question, because it's still, what does that mean? Little difference based on age, but 80% said that miracles still happen based on, as in ancient times. And this was the majority of every religion, even those unaffiliated with any religion, except for Jehovah's Witnesses, which was the only outlier. Much less believed in miracles. But everybody else did. Doesn't matter. Some, again, there are a lot of religions who specifically don't believe in miracles, but they fall into this category. So exceedingly common. And if you actually look at, in the context of healthcare, exceedingly common too. So this was a survey done in Archives of Surgery in 2008, 1,006 adult Americans and 774 common professionals. And the question was to them, this is part of a bigger study, but near the end of the survey, a patient in a permanent vegetative state could be saved by a miracle. 61% of public respondents believe this. 20% of trauma professionals. And this was not just physicians, but nurses and other allied health staff. And the second question they also asked in this was, divine intervention from God could save a person even if the physician told them futility had been reached. The majority of public respondents believe this. So, close your eyes again. I'm going to do the same thing at Grand Island. Close your eyes. Close your eyes, close your eyes, close your eyes. How many people in this room believe that a patient in a permanent vegetative state could be saved by a miracle? Okay, lower your hands. How many people believe a person in a permanent vegetative state cannot be saved by a miracle? Okay, lower your hands. Outcomes, one person in the room believed that a person in a permanent vegetative state could be saved by a miracle. Everybody else did not believe that was true. So when we're thinking, and this is kind of the light bulb moment for me, is that when we're thinking about miracles, we may think of it from our framework, from how we perceive the likelihood of things are going to occur. We are the anomaly. The patient's mother is not the anomaly here. Most adults in the U.S. do believe this could happen, and do hope for it. And it's important to remember that when we're going into this room with this mother, is that she is not the one that is atypical. Is that everybody in this room, except for one person, is the atypical person. And it's just the way to frame your discussion. To get your mindset ready is that as physicians, we have entered into a new culture. And we are being enculturated. That's what medical school is all about, enculturating yourself into the culture of medicine. So it gives us a framework. So the second question is, among patients with advanced illness or their surrogates, what is the meaning of hoping for a miracle when used in medical decision? So what do people mean when they hope for miracles?
They want their loved ones to wake up and walk out of the room.
Okay, so it may be an expression of just a desire. I desire that it's a hope for a specific outcome. Anything else?
That the doctors are wrong
That the doctors are wrong.
in this case.
Yeah. That you don't know everything. You're not God. Or that just uncertainty. What else?
What about like just confirmation in your own beliefs? Like I know Catholic population is really large in San Antonio, and Catholicism is a lot of guilt placed with disease, and so people think that, oh, grandma's in a coma, like what did she do wrong? And so they want to prove that she's still a good person. So if God can perform a miracle and make her all better, then she really wasn't evil, and she's really not going to purgatory. She's actually a good person, and she's gonna, confess for those sins. So I think it's even just confirmation in like mom or family member's own belief.
I went to 12 years of Catholic school, so I'm well versed in guilt. And it may not just be about the mother. It may be,
Right.
this is a test of my faith. If I give up on her now, it means I failed. I'm the one who's guilty here, not her. So that's what it could be. You know, other things to consider too. Again, to think of it in a broader sense, this could be a belief. So the hope for the miracle could be a belief in a divine or supernatural intervention that supersedes the law of nature. This is probably how we generally think of miracles in the general public. It could be a manifestation of denial or of impending loss. It could just be an expression of hope or optimism of the possibility of an expected outcome, separately from faith, separately from divine intervention. It could just be like somebody is hoping for a very unexpected outcome. And we know from population-based data, unexpected outcomes happen all the time. Miracles will happen all the time using this definition. Just because unexpected things happen. 1 in 10,000 things happen. 1 in a million things happen. If you do something a million times. And it could be an expression of anger, frustration, or disappointment over certain aspects of the note. And I think this is an important thing to remember. So, Cartoon says, I sure hope that the negotiations go well. Elephants are us, the physicians, the people wearing the white coat, in discussions in the ICU or in the hospital with family members. They're coming into this with very little knowledge about medical facts, very little knowledge about statistics, and everything that we like to talk about in medical family meetings. So it's very hard. So what sometimes may make it easier is you throw in your faith. It's like the trump card. I'm hoping for, I don't care what you say, I'm hoping for a miracle. It's that expression of frustration or anger. And if you actually look at what it means, it also means that you may be the person that they're hoping for how the miracle is going to actually occur. So this is a telephone survey of 1,000 people in the southeastern United States. Again, 88% of respondents believe definitely in miracles, given the fact that most U.S. population does. 63% responded definitely believe, and 80% said they believe God acts through medical doctors to cure sickness. 49 reporting that they definitely believe this. So I used to use the question, sat down with them, I thought it was very smart. You know, if a miracle happens, it's not going to come from somebody wearing a stethoscope or a white coat. I thought that was a nice way to frame it. But it's generally, sometimes, again, probably more commonly, not what people actually believe. They think you are the means to the miracle. So that miracle is going to come from somebody wearing a white coat and stethoscope. You just don't know it. So it's an important, again, part of trying to think about how best to approach this is where are people coming from. So, and I think the other important thing is, because we don't know, and there's a lot of different things how people, what people mean when they hope for miracles, what should we ask? Again, going just to like about our level of curiosity about different cultures is just to ask. So can you tell me what you mean by your hope for a miracle? It could, the response could be, I have faith in God. I have faith that things are going to turn out, and if I don't hold on to that faith, that means I'm a bad Catholic. Or it could mean I realize that the prognosis is abysmal. I just have to hold on to something right now because I have nothing left to hope. And the way you respond to those two things are very different. They should be very different. People are coming from very different paths when they're saying that. So the third question, among patients with advanced illness or their surrogates, does belief in miracles or divine intervention influence medical decision? Do we think it influences medical decision making? Hard question to get to. Again, all these follow a similar format, the PICO format as far as developing questions. So this is one study, Annals of Behavioral Medicine. 68 African American white patients with advanced stage lung or colon cancer, and they asked the question, to what extent do you believe in divine intervention or the possibility of a miracle that might change the course of your illness? When they actually looked at confounders and adjusted for it, what they found was belief in miracles was associated with higher rates of wanting to be full code and having CPR. So in this regard, it does. There's not a whole lot of other evidence to help us. There's some though. So this is from the Coping with Cancer trials, looking at 345 outpatients with advanced cancer followed from baseline until death. 78% reported that religion helped them cope to a moderate extent or more. And people who used positive religious coping, not negative ones, not like I'm going to burn in hell religious coping, positive religious coping, at baseline was significantly associated with the receipt of mechanical ventilation during the last week of life. So more likely to use mechanical ventilation if you use religion to cope with illness. More likely to use intensive life-prolonging care, less advanced care planning in all forms, including DNR orders, living wills, and total power. Which has always been the part that confused me the most, is that if you truly believe in heaven and hell and life after death, why is it that this would be this significant? There's a lot more that goes into these decisions. Faith definitely plays a role. And you can argue that these numbers aren't huge difference, but there is a statistical significant and probably clinically significant difference here between people who use religion to cope and those who don't.
I have a question now.
Yeah.
Have you experienced that? I'm just asking.
Yeah.
So people feel that they're going to hell, want to live longer. Are those the ones who...
Say that again?
You're saying that people believe in heaven and hell and people believe in miracles, right?
Yeah.
So other people who are expecting a full call living longer are the ones who expect to go to hell because they have care.
Yeah, I don't know that. Again, what we do know from the literature is that people who are religious on a population-based level are more likely to want very aggressive care. Why they're choosing that, we don't know. It could be a lot of things. It could be around guilt. It could be around it's their faith. We'll talk about this next slide really kind of goes into it. It also may be in the way we communicate with those patients and in their ability to actually trust our prognostic estimates. And this is what this study actually goes to. So this is by Lucas Ayer and Doug White, who was at UCSF and now is at I think Cincinnati or Pittsburgh, University of Pittsburgh. And what they did is qualitative and quantitative study, mixed method, 50 surrogates of critically ill patients given hypothetical prompts regarding their loved one. The majority expressed a reluctance or unwillingness to believe a physician's futility predictions. And this was not a gray and white futility. This is not a qualitative futility. This was absolutely no chance of surviving hospitalization. Absolutely no. There's no less than 1%. Absolutely black and white, no chance. And what they found, 4 main reasons why people have reluctance. Skepticism about our prognostic abilities. People doubt our ability to prognosticate. They need to see them for themselves that the patient was incapable of recovery. They need to triangulate multiple information sources before they believe physicians. And they also have a belief that a God can intervene to change the course of a hopeless situation. So these are the reasons people may not believe. And this is a futility decision. Does this also hold out for prognosis? Same group. But again, a third here doubted the physician's ability to predict futility based on religious grounds. So in a hypothetical scenario, more likely to request continuation of life support despite very poor prognosis. Follow-up, patient or surrogates. These are questions to surrogates. Actually went to surrogates of patients in the ICU setting. So these are people who are dealing with this stuff on a day-to-day level and ask them questions. Hypothetical scenarios in the last one. Same thing here. Only 2% of surrogates relied solely on physicians' estimates that come up with their own prognostic estimates. So only when you say to somebody, to a surrogate, I think that they have, less than 1% chance of surviving. Only 2% of surrogates will only use that piece of information to come up with their prognostic estimate. We think it's 100%. It's not. What do they use? They use lots of different things. These are the 5 big themes that came up out of this article. They use knowledge of the intrinsic qualities and will to live with a patient. He is a fighter. He's going to make it through it. You think he's going to die, but you really don't know him. I know him. I know he's a fighter. Surrogate's observations of the patient. Oh yeah, but he blinked his eyes yesterday. That means he's going to do a lot better. Patient's history of illness and survival. He survived prostate cancer. He's going to survive metastatic lung. Surrogate's belief in the power of the support and presence. I just have to make sure I'm here every day in the ICU. I have to make sure in the CLC hospice unit that I never leave. And he's going to get better. Their optimism, their intuition, and faith. So if I just maintain my faith that he's going to get better, he will get better. This is how people come up with their prognostic estimates. It's not us. They use some of us, but not all. I forget the exact proportion, but most actually do use a combination of what we tell them and what they do. So just to think, when we're talking about prognosis with patients, we should also ask them, after we tell them what the prognosis is, did that change their mind at all? What do they think the prognosis is? How do they come up with their prognosis? It also tells us, when we tell them about prognosis, when we tell them that we think it's days to months, or days to weeks, months to years, we should make sure that because of this, intrinsic qualities, because of history, is that we frame it in some type of context. We tell them why we're thinking that it's hours to days. We don't just say to them, oh, we think he's dying. We say, because of this, this, and this, we think he's dying in the next couple of hours to days. Is that what you think? Tell me how you're coming up with your own estimate.
Eric, I was going to say that talking about the culture of the miracle, especially in minority groups, Hispanics, Catholics, and Dr. Finley has done research in that area, and African Americans and their beliefs, and all of those issues. It's very interesting when you ask the family the question of, when you said that they're going to get better, what exactly do you mean by, or what are your expectations?
Yeah.
And I think part of the process of working in all of those very interesting data that you're showing is a process of narrowing down little by little in the conversations expectations, and at some point hopefully the expectations will match the medical illness and the preferences, and you will narrow to a more specific prognostication. But I really think it's very important to us what they mean by the miracle, and that's how we have worked around cultural aspects of what exactly the miracle will be here, and the fears of death and dying. When in some point in the process of working with the families, death doesn't become an enemy anymore. And one more thing, in cultural care, we have a lot of African Americans in my nursing home. There is no much more powerful tool than having an African American member of my team.
Yeah,
delivering that. You said that. Did you?
That goes into. Did I have it on here? Trust. I think I have trust in here.
Tons of trust issues in the African American community.
Well-deserved trust issues too. So that's a really important factor. There may be lots of trust issues. So, not to say that discussing prognosis is bad. Again, based on my last 2 talks, I think prognosis and discussing prognosis is bad. It's just really framing it and using it as part of your communication with patients. So the last 2 questions, we have about 9 minutes. Among patients with advanced illness or their surrogates who open miracles, Does support of the spiritual needs by medical teams decrease the likelihood of aggressive end-of-life care? So, using your chaplain, discussing spiritual assessments with patients. This is again cancer, coping with cancer study, 343 outpatients with advanced cancer followed from baseline until death. Are they getting support? 60% said their needs were minimally or not supported by the medical system. So we're not supporting these patients spiritually. 54% said that they had not received pastoral care visits. These are people with, again, outpatients dealing with advanced cancer. And then the question came up, does spiritual support by the medical team impact outcomes? So if you looked at the entire sample on this study, people who said that their medical team spiritually supported them had a threefold greater odds of receiving hospice care. But there was no association with aggressive end-of-life care. However, if you look at those patients that we talked about before, the religious copers, people who use religion to cope, again, those people are more likely to use aggressive end-of-life care. They're more likely to receive hospice and less likely to receive aggressive end-of-life care. So just incorporating spirituality and having a discussion about that actually may reduce conflict and also may decrease aggressive end-of-life care. We don't exactly know from this study what was included in spiritual support. This is spiritual support from the whole medical team, physicians, chaplains, and nursing staff. How that was provided was not part of this study. But this is really the first evidence that we have is that actually supporting people spiritually actually may impact outcomes. And then the very last question, among patients and surrogates who hope for miracles, is there a communication approach that decreases the likelihood of aggressive end-of-life care or improved outcomes? Tons of review articles how to do this. Really, as far as I can tell, only one real study, randomized controlled trial. This was in the New England Journal. In family members of 126 dying patients in 22 French ICUs. The intervention group received proactive end-of-life conference and a bereavement brochure. The control group just received usual care. And the communication system that they used was value. Have you guys heard of value? Basically the things we talked about. So value and appreciate what surrogates communicate. What they're communicating is important. And to express back that you actually value what they're saying. Acknowledge their emotions with reflective summary statements. I can see that you're very angry right now. Can you tell me why? Listen carefully. In the intervention group, significantly less time was spent actually talking. Much more time listening. Understanding who the patient is as a person by asking open-ended questions. Can you tell me more about your father? What was life like for him a month ago? What was life like for him a week ago? Elicit questions. So what questions do you have about what we thought his prognosis was? Can you tell me more about what you think his prognosis was? Do you have any questions about what's happening to him in the ICU? When we actually looked at this, conflict was decreased in the intervention group, increased number of relatives who actually agreed with the physician after initial disagreement. Regarding decisions to forego life-sustaining treatments and bereavement outcomes, 90-day post-mortem follow-up, decrease in symptoms of PTSD, anxiety, and depression in the bereaved surviving family members. Again, just a graph that shows bereavement outcomes all improved in the intervention, all statistically significant. So to summarize, believe in miracles, common. Were the abnormal ones, likely impact decision-making at the end of life. It is important to determine the meaning and significance of a hope for miracle. That a hope for miracle, like people who are wanting everything can mean a lot of different things. Hoping for miracles can mean a lot of different things. It's really good to get a chaplain involved. However, spiritual support by other members of the medical team remains just as important. And proactive communication that values what surrogates say may open lines of communication so all parties can appreciate the full range of options when available, including those that ensure comfort while maintaining health. And I think this is probably the main point of this talk, is that just the key is to open lines of communication. initially, that picture of the physician out there, lines were closed during this case. We want to open. So if we actually wrote this up more in detail. Did this with Ken Rosenfeld at UCLA, Eric Fromay in Seattle, Dan Silmazy, who's also a chaplain, and Bob Arnold at Pittsburgh. The cartoon says, I think you should be more explicit here in step 2. Then a miracle occurs in his proof. So I wanted to make sure that we open up at least a couple of minutes for questions.
What happened with that patient?
About 14 days, no, about 7 days later, we took him off with consent with the family and agreement with the family, with the hope of keeping him healthy. And he died immediately thereafter. I think the other key lesson is that for us, it was a black and white decision. He's dying. And we talked about this before, this is the first time that they've dealt with this. This is the first time she's losing her son. The emotional content is huge, but also she just needs time. We think, oh, but there's like 7 other people who need ICU beds, and what about resources? And she's not thinking about that. And when you ask patients, what they often need is time. And in the grand scheme of things, 7 more days in the ICU matters much less than 2 more months in the ICU. Just remember, the key is opening up lines of communication, and sometimes that's just giving space. And I doubt if we gave space, if we didn't give space, we wouldn't have gone, he wouldn't have been extubated at day 7. He would be on the ventilator until he died. And we actually talked to the wife, the mother later. She was actually grateful for everything the ICU was doing. Thank you.
Thank you. On behalf of the both fellowships, Eric, thank you so much for using some of your vacation and just sharing with us. It's wonderful.
More than happy to.
Thank you so much.
Yeah.
Enjoy San Antonio the rest of the week.
Thank you.
The reason I'm going to play is that I